Hello and welcome, everyone. Volume check. Welcome, welcome. Awesome. Hope you're having a fantastic new year, 2026. For me, this is a rather amazing year. Oh, excuse my voice. This year has started off very productive for me. Welcome to Nurses in Charge. This is our podcast, Share Your Nurse Story. And today we are sharing some stories that are worth telling. So welcome, welcome, welcome. Okay. This is Nurses in Charge, a faith-based nonprofit organization with members coming from various nations around the world. So we say thank you. My name is Dr. Nyepu Kemo Paul. I am the founder of Nurses in Charge. I serve you here, and it is my pleasure to serve my fellow nurses and midwives globally. So thank you for joining us. We welcome your comments. If you are streaming from YouTube and or Facebook, we say thank you for returning. This is our second episode for 2026. So I am so excited to be sharing this episode with you. Feel free to join me on stage so we can have a conversation here. Grab your cup of tea. And yeah, it's really good for my voice today because for some reason my voice is, yeah, honey and tea. Grab your cup and join me. This is a laid back conversation we're having today. I have a little to present to you all. And okay, welcome everyone. There are indeed some trailblazers, many trailblazers among us. Some we know within our workplaces, others we have heard about just in history. So I want us to take a deep dive into who these trailblazers are and to actually just look at what, first of all, what does it mean to be a trailblazer? What does that term mean? You are a trailblazer. I am a trailblazer, but what have we done, or what has the nurse and or a midwife done to be classified as a trailblazer? So if you were the first to invent something, what could it be? If you were the first to start a certain business, right? A business idea, a niche that is just so unique and is saving lives and is propelling the journey for others, and others have come along and just appreciate you. What could that be? Share your story. This is why we host this podcast, because we believe that there are nursing stories out there that are untold. There are nurses that are yet to be discovered in what they have done, what they are doing in their various countries. And actually, this entire mindset took us to our first, it took us on our first nationwide tour in Liberia. And we're still working on our documentary. And this documentary, this tour is called NIC Tour. So we are highly interested in discovering nurses, midwives who are making their marks out there in their various corner, I would say, parts of the world that no one has heard of, and no one really may not care to tell these stories. But we do our Nurses in Charge, where we connect nurses, we celebrate nurses, we empower nurses, and that those pieces where we connect come into Nurses in Charge, and you will be amazed because we are a big family, a big. Have you seen that movie called The Big Greek Wedding. Your Big Greek Wedding. This is your big um, nursing midwife family global. Your big global nursing midwives. Charge, you will hear some of us saying sister or calling each other brothers. And it's because we are comfortable with each other. We should make the world a smaller place for all of us to have a short conversation, just tap into each other's ideas, call a nurse friend or a nurse buddy out there across the globe and just say, hey, I'm working on something out here in Liberia and or in Jamaica, and I just wanted to see if you guys are doing that in your country. And or I'm working on, well, I have a patient that is so complicated. Have you ever dealt with this? And just having that opportunity and using that opportunity to check in on a nurse friend, a midwife friend, check on them, check on their well-being, check on their career development and or any initiative they are undertaking, and collaborate with them. This is the mindset of Nurses in Charge Global, because we no longer want to be in a world where nurses are total strangers to each other but doing the same thing, um, and or nurses um, are making big waves out there and no one's hearing about it and not being recognized, not being appreciated or celebrated. And the last thing of that is that empowerment piece, where if you um, don't have the same um, academics standards globally, which it makes sense that we would have diverse approaches to how we get trained, how we get prepared for the real world, get our curriculum developed and carried out, because the world is large. But we are nurses in charge. We are building a baseline, a standard for nurses and midwives globally to understand the same, to have that um, professional uh, um, uh, cultivation, I would say, and or professional preparation that just makes sense across the board. Where if you are from Europe, you're from Asia, you have done that, you were trained that way, and or you have that knowledge base to carry on your work um, on a daily basis. Whether you are entry level nurse and or a doctoral level nurse, just making sure we're bridging that gap. And when I say bridging the gap, it brings smile to my face, because this is our mentorship piece to Nurses in Charge. We do have three pillars. We have the education, research, and mentorship. So please do visit our website and visit our website. And I just launched the um, the link up there. You have now streaming there across the screen. You have our website, nursesinCharge.org, and you also have our email, thenursesinCharge@gmail.com. Send me an email if you want to co-host with me, share your nurse story. We do have a link within our website that you can share your nurse story as well. We have a community that we're building up and expanding that community so that our members globally can meet, congregate, and conversate and do have that dialogue among themselves from wherever they are. So I see someone joining me, people are coming through. I was just giving some background knowledge about nurses in charge out here so that those who are brand new to nurses in charge can get the gist of what we are all about. So welcome everyone. Feel free to use that link and come on stage with me. Let's have a conversation. And or if you are at work and or have a prior engagement, and can I join us on the set today? Just put in, tell us where you first of all introduce yourself. Tell us where you are viewing from, and share the link as well with your social media buddies so they can come true as well. Even if you're at work, share your story with us, and feel free to pop in, pop out. I will be here for the next 20 more, no, I would say 40 more minutes. So today, as you can see across the stream, we are acknowledging, recognizing, shouting out trailblazers among us, honoring the pioneers of nursing and midwifery. So again, thank you for joining us on this second episode of the Nurses in Charge. Share your nurse story. Perfect. So I want to take you all. First of all, let me take a sip of my tea, wet my whistles, as the word goes. Perfect. Drink your tea with me as well. Here we are. I've made a list of so many trailblazers out there. Trailblazers among us, trailblazers that have made history, and we are still benefactors of what they invented and or what their research projects were all about that has changed society today, that is still impacting lives, saving lives. So yeah, I have a list here. I want to first start with encouraging you all to register from our website. Register to join us on this coming Saturday. Will be our second annual Kickstarter event. And this is the basis of why we're here today as well, because this Kickstarter event is all about the trailblazers within Nurses in Charge, the trailblazers that we are recognizing. They may not be yet members of Nurses in Charge, but we do value what they have founded, what they have invented, what they have written that are changing lives, and no one is talking about them, no one is cheering them up. So that event starts at 10 a.m. on Saturday, January 17th. It will be virtual, so do visit our website and register, get your free ticket. No price for registration. This is all free, just to kickstart our year honoring the trailblazers. This is the year of the trailblazers, and Nurses in Charge is honoring trailblazers globally. So feel free to tell us your story. If you're out there, no one has discovered you. Hey, we're here to cheer you up. We're here to recognize you and make an entire global recognition of you out there so the world can see who you are, what you're doing, what you've done, and how your work is impacting lives, saving lives, making patient care outcome the best. Uh, we cannot thank you enough for what you are doing out there, but we can make your we can feature you and make, let the world know what you are doing out there. Okay, so please do join us this coming Saturday from 10 a.m. to 12 o'clock noon, Eastern Standard Time. So convert that time into your time zone and join us um, that day. It'll be amazing. You'll love it. You'll learn a lot about nurses in charge, and you can be featured as well. It's not late. We have till Monday for submissions, which is Monday is tomorrow. Yeah, for submissions of the um, the trailblazers that will be featured. So tomorrow is the last day to submit. Okay, who's out there? Tell me where you're joining me from. I am in Florida, USA. I'm originally from Liberia, West Africa. So, yeah, grab your cup of tea, guys. Don't forget that part. Today's Sunday. Don't know if you went to church. I worked the night shift, came back home very tired. Did not get to go to church today. I slept in and read my Bible, did my own little devotion. Don't know what you did today. Share with me where you're joining from. Are you a nurse, a midwife? Are you entry level? And or you've been practicing for many years? Or maybe you are retired and you have some time on your hands that you can join me and help me lead nurses in charge. I am always on the outlook for nurses and midwives that want to lead with me in nurses in charge, because this is a global organization, and one person, few people cannot lead nurses in charge. We do have, though, we have five, currently have five um, regional directors, and this is the year, talk about trailblazing. This is the year we are transitioning to brand new regional directors. So our current regional directors have served for 2 years, and we are moving them into our advisory board. They are now, they can tell us, how to run the show. And we truly and highly appreciate their efforts, their supports, their services over the past 2 years. So we will also be honoring them at this event. So please come help us cheer up these amazing leaders. So what else can I tell you? Our board members, um, they are under a year within the current board. They are under a year within their service to NIC, and they are making an amazing journey for us. Um, who else we have? We have chapter leaders. And if you are from a country that currently does not have a chapter of NIC, woohoo, please come on board and build your community within your country. Be that ambassador. We're always on the outlook for um, on the lookout for ambassadors to the nations. So the ambassadors work with the regional directors. Then we had local chapters leaders that work under the umbrella of the regionals and ambassadors. So please keep this information in mind. If you are that leader, and or if you do know someone who is a potential lead, send them our way as well. Um, yeah. What else is happening? And I see I will throw some information to you here and there. So let me just get going with the trailblazers among us. going with my list here. And it behooves me to honor um, the pioneers, and then from the pioneers from the 1800s, really, that's what I meant, and then bring us to current date, right? What is documented of nurse trailblazers, midwife trailblazers out there that we can recognize today and honor them on this show. I see a comment here. All right, D. Roberts. Awesome. Thank you, Dee. Thank you for joining me from Facebook. I see. My pleasure serving you all, and I see is my God-given pleasure, my talent, my God-given gift. All right. I love serving nurses and midwives, and I just never knew my purpose till God revealed it to me. About, I would say 5 years ago, and I am living my best life. So, and if that is something you want to discover, discover yourself, discover what your purpose is. This is one chick who just never knew what God has called me to do. And when I requested, God provided, and He led me, and my life has been a complete, awesome, amazing life. Okay, here we go. That's about the event coming up. So please plan, save the date, and join us this coming Saturday. You'll be amazed. Um, if you want to participate in um, by any means, let us know. Okay, perfect, perfect. Okay, so again, welcome to Nurses in Charge. This is our share your nurse story. Perfect. All right. So let me start with historical foundations in trailblazing, starting with modern nursing education. This is Florence Nightingale. She established the first professional nursing school at St. Thomas Hospital, and she is known as the nurse, the lady with the lamp. So we know that Florence Nightingale is the founder of modern nursing. Okay, then she went on to establish um, established the first nursing school at St. Thomas Hospital. This is in 1860. Okay, dating back that far, guys. She also designed the rose design is called, or coxcomb. It is a statistical diagram, because Florence Nightingale was into research. She wanted for the world to know that research breaks barriers, that research is an amazing tool to change how we do things, how we care for patients. So the science of nursing, she is always will be the scientist that open the doors to evidence-based practice nursing. So when she designed the Rose diagram, it really did help us. It was able to show mortality causes, right, during the Crimean War. So she revolutionized public health and advocated for data-driven decision making. So if you're getting goosebumps, great, because when we use these diagrams today, it's, statisticians can use these diagrams today to really show, the impact of diseases, the impact of meaning mortality rate within a setting, of you know, a specialty of nursing and or midwifery where there's a mortality rate. So you search up that name is called Coxcomb, Coxcomb, and or it is called the Rose diagram. So that is the two I picked out from historically to bring it into this conversation today. And now the next invention I want to mention to you all is none other than the cold cart. Do you have a cold cart at work? Put that in the comment section. Let me know if you have a cold cart, also known as the crash cart. This is the cart that we grab and run with to our patients' rooms when there is a cold, it be cold blue, or yeah, it has to be related to a deterioration in a patient, and we have this crisis alarmed, alarming us to resuscitate a patient, and this card has all of our supplies on it. It has the defibrillator sitting on it. It has an ambu bag. It has IV starter kits on it. It has medications on it to be able to give to this patient, cardiac drugs. It has uh, yeah, when we are conducting our basic life support, doing our chest compressions, this is the card that it is our companion. That on that card we can put the defibrillator on that patient to analyze their rhythm. Our AED is on there, and let me know what kind of AED are you using currently as well. And what is on your crash card? Even if you're watching this show after the show, just comment and let me know what is on what's on your what are the supplies on your crash card. Make an itemized list and just wow me. So because I'm interested to know what's on others crash card and what's not on others crash card, and that would be another segment where we can compare. Why didn't you have this on your crash card? That's the title of that podcast. Why don't you have this on your crash card? So the crash card was founded and or I would say invented by Anita Dorr, an RN. She's an emergency nurse who invented the rolling cart with essential resuscitation tools. The use of this is to centralize medications and equipments for cardiac slash respiratory emergencies. Kudos to you, Anita Dorr. And we do have the feeding tube. Are you using feeding tubes at work? Do you work in med-surg? Do you work in a clinical setting? You will have a knowledge of what the feeding tube device is. And Bessie Blunt Griffin, an RN, is the founder of the feeding tube device. Okay. Designed self-feeding tubes for amputees unable to feed themselves. So Bessie Blunt Griffin designed a feeding tube device that helps amputees who are unable to feed themselves. So we want to recognize Bessie for enabling independence in feeding oneself, for paralyzed patients, for patients who are with some physical limitations to feed themselves. And this feeding tube really comes in handy to help these people. So early assistive technology predicting many modern devices. And also comment to this episode and let me know what type of feeding tubes are you using at work. And if you do know who invented that particular feeding tube, I would appreciate that from you all. All right. Next, we have the neonatal phototherapy for midwives and nurses. So nurses developed the light-based treatments for newborn jaundice. Nurses invented that, not doctors, not lawmakers. Okay, we are professionals. Okay, here we go. The neonatal phototherapy to treat jaundice in newborns. It uses light to reduce bilirubin levels safely, right? Um, it has saved and continues to save millions of neonatals' lives globally. Um, Also, if you work in the NICU, and I would love for you to share what your phototherapy for babies born with jaundice, what are you treating them with, what your phototherapy device looks like. That would be amazing to share that with me. Share it with the world, because when you do post that, the entire world will be seeing that. Okay. And I want to recognize you all who will be participating in this follow-up event. All right. And next we have the anti-embolism stockings. Have you seen those stockings, the tight stockings that patients are not so fond of? And some nurses and midwives are not so fond of because they were meant to be tight because they help to return blood flow and help the uh, leg muscles return blood to the heart so that patients don't um, end up getting DVTs, and DVTs that can turn into pulmonary embolism, and patients can lose their life due to that. So here's the background: that nurses advocated and refined compression garments. Okay, we see here where um, the anti-embolism stockings, they prevent deep vein thrombosis in immobilized patients and or surgical patients, right? So the idea is to for pre-surgical patients to put on the the stockings so that when they do come out of surgery they already have it on, because when they come out and their belly ache or their surgical site aches, it's not a suitable time to be putting these tight stockings on. So evidence has shown that if we you know have our patients put on the stocking or help them, because they do need help putting on these stockings, it really helped them so that when they come out of surgery, they already have the stockings on, right? Because during that time, during surgery, while the patient is not moving and being still, it may be the fact that they are under anesthesia. The stockings really help so that blood does not pull into the venous spaces and start to coagulate. Okay, so the major role in patient, this is a major role in patient safety and mobility care. All right. Next, we have the walker attachments for IV and trays. Oh my goodness. I can't wait to show you pictures of these inventions. It's amazing what nurses are inventing. So background knowledge is that um, it innovated. It is innovated by rehab and home care nurses who invented the walker attachment for IV and trays. Okay, this adds stability and functionality to mobility aid, right? It enhances independence and safety during recovery of our patients. Thank you guys. I see you guys are joining me now. Thank you so much. Thank you for the likes. Send some hearts, like and share. Anything you can do to promote NIC, you are highly appreciated. Introduce yourself. Tell me where you are joining from. Tell me if you're a nurse, midwife, or both. There are some professionals who are nurses and midwives, dual professionals, and I love that. One country that I realized has that role is Liberia. I don't know about other countries, so let me know where you're joining from. If you are one of those who carry the dual licensure for nurses and midwives, kudos to you. Tell us how you share your nurse story with us, right? Why did you become a dual certified nurse midwife? Would be amazing to share on this podcast one of these days. So feel free to send your information to the nurses in charge at gmail.com. Let's keep rolling on. So communication, the next category is communication, decision, and documentation systems. How has nurses and midwives contributed to this area of invention or innovation? So the F bar, have you ever written an F bar note? Listen, guys, this was not founded and or invented by none other than nurses and midwives, okay? So this is the situation, background, assessment, and recommendation documentation tool. So when you're giving report to someone who is receiving your patient, and or you just calling a doctor to give and or a nurse practitioner to give hand of report to a patient within their care. This is an amazing tool. And the military has really used the SBOT tool to communicate among themselves, especially in the clinical setting as well. It is to the point precise communication between two clinicians. And I tell you no lie, no matter where you work, when you use the SBOT tool, it really makes the communication being conveyed um, um, to the point. You're not saying less, you're not saying too much, you are just giving exactly what the receiver of that information needs, and then the feedback of that is productive. It goes to really propel the communication between two clinicians and or more, because some people come later on and they are able to get that information and run with it and work with it. Okay, so nurses in the U.S. Navy and in the U.S. Navy were the one that invented the S-bar note. Okay, and later on we have gone to refine it and make it even better today. So the S-bar note, SBAR communication tool is one that was invented by nurses in the Navy, U.S. Navy to be precise. So this is a standardized clinical communication tool. It is a communication tool being used across team dynamics. Um, it reduces error and improves care transition. And I've seen it being used when a patient is being transferred to an like the care is being upgraded or downgraded wherever the patient living from ICU um, to PCU, and or from just one patient moving, transition of care to be on point with this conversation. So this is a major um, uh, impact. And I would say it really has brought communication clearly among team members. What about the sub notes, right? SOAP, spelled just like you're using the soap to take a bath. So the sub note also is a documentation format, right? And nurses formalized the subjective, objective, assessment, and plan format for documentation. And this is a universal clinical note that is standardized. It is amazing when you follow the sub note, you can definitely document your patient care and subjectively, what did the patient tell you? Objectively, what did you assess on this patient that is measurable, right? um, and then the assessment finding for this patient, and what plans, right? What plans are we making in this patient care based on our assessment, based on the subjective and objective data that has been obtained during our interaction, our encounter with this patient. So the subnote is a universal clinical note, standardized. It's standardized clinical note. And nurses invented that. All right, let me pause for a moment and see what's in the comments. Okay, Kendria, welcome. I see you on Facebook as well. Hello, my dear. Um, already. I see D is on there as well. Who else is joining us? Please feel free. Thank you all for coming along. And if you have been following, you will realize that I am on the, I would say now, protocols and assessment tools. This is the number 10 on the list of inventions that nurses and all midwives have come along with to make our work easier, to just make our lives and our patient care outcome the best, right? So now this category is protocols and assessment tools that have been invented by nurses. For a drum roll, for those of you who have ever used the Wong-Baker faces, these are facial features that tells you if a patient is in pain. Sometimes our patients cannot speak, and or they may be confused, right? They may have their mentation may be altered. So the Wong-Baker faces really, you can use that for a patient who is able to point to the illustration, the facial expression to tell you what their pain is, right? And if a patient is not able to show you on that, you can actually look at their facial features, grimacing. If they're grimacing, you can use this tool to evaluate their pain level and treat them appropriately. Otherwise, we just don't have a tool, right? So this is a pain assessment skill. It was developed with nurse input to help patients report pain. It simplifies pain evaluation for children and nonverbal patients, right? It improves pain management practices. Have you ever used the one Baker faces? Let me know. Put that in the comment section. Or if you have other tools that you're using to assess your patient pain, um, please do let me know as well. And if you have pretty knowledge of who invented that tool, would be even better. Okay. The number 11 is neonatal safety sleep protocols. So pediatric nurses championed safe sleeping environments, and they then invented the sleeping protocols, right? It reduces risk for sudden infant death syndrome. So with this, public health, it has a major public health benefit for infant safety, because here we are, parents take their infants home, and they may be new parents, right? And or the inexperience with um uh, parenting can pose risk to these newborns, right? So the protocol for keeping these patients, keeping these infants safe, and for the incidence of sits to not occur, the protocol really goes to save lives in this area. Wow, this is amazing. um, Sudden infant death syndrome, it is not something to play with. Sometimes parents wake up and the baby is dead. Whoa, what happened? What could have gone wrong? Did a baby roll over? Did something, suffocate the baby? We don't know. So this protocol really is a life-saving invention. Before we go to the next category, the last on this category of protocols and assessment tools is the PCA protocol. What is PCA protocol? If you may have never heard of PCA, this is patient control analgesia. So you have this pump that patients can, readily administer their own pain medication. It could be morphine. It could be um, uh, what's the other drug? It could be morphine. It could be hydromorphine, which is the Dilaudid. When I worked in surgery, and I would say post-surgical patients will come with their PCA pumps. And besides that, also patients with sickle cell anemia, they really do benefit from the PCA pump, because they really need that constant pain control, that regimen to keep them comfortable, to keep their pain under effective control. The PCA pump really goes to help them. If you have your cup of tea, feel free to drink it along with me. Um, I love tea. I don't know about you. Tea really helps me to calm, relax. So feel free to grab your cup of tea as well. Here we are. So the PCA, let me give you some background knowledge here. Nurses helped develop pain pump safety and guidelines. So the guidelines really helps us to keep this practice safe for our patients, for monitoring, assessment, and evaluation. It allows patients to manage pain within safe limits. Okay, it enhances patient comfort and autonomy. Listen, if I was in constant pain and my nurses did not have to jump the hoops to come give my pain medication to me, and I could, administer my own pain management, my own pain regimen, life is easier We just need a protocol, right, to make sure the practice is safe, to keep our patients alive, and to evaluate their pain regimen. Okay, the impact of their pain regimen. Before the next category, I am going to check with comments here coming through. Minister Francis Dimley is here with me. Thank you, Sis Francis. Yeah, I'm here following the discussion. Thank you. Thank you, Doctor. Thank you, Dr. Nyapu, nurse. Thank you so much, Sis Francis, for coming along. You're always in my corner, checking me up and cheering me. I appreciate you. You and Kendria. If I've ever had a podcast and sitting here and having conversation, two people, I would say three, that I can close my eyes and know that they're there. One is Kendria, one is Sis Francis, one is my mother, Nayo. I'm surprised that she's not on today. She's in Liberia and maybe network is not favoring her, but she is my number one fan in the whole wide world. Imagine your mother, a nurse of over, I would say, 40 years plus, and she is always there. She was on the first podcast. And so I'm surprised Nia is not on today. I love you, Mom. Love you, Sis Francis. Love you, Kendria, my sister, up there, out there in the UK. Thank you, ladies. Thank you, friends. So back to the topic. Don't get me going. I love my NIC crew. They are the backbone of this organization. When they tell you they'll be there, they will be there. Okay. And when you're there talking and you wink, you'll see an NIC member joining you and cheering you up. And yeah. So if you guys, if you have any experience with any of these inventions, please chime in and let me know what your experience is with any of these. Our next category today goes to systems and workflow innovations. Systems and workflow innovations that have been invented by nurses and midwives. Okay, this one is color-coded triage tags. You're probably wondering, what are you talking about? The color-coded triage tags. Emergency nurses refined the triage tagging for disasters, right? Because sometimes when you are, I would say quite often, when you are in a disaster response algorithm, right, and that disaster response is in motion. That's the word I was looking for. You want to grab the tag that correlates with that disaster response and run with it. It saves time. It's just on point. Can't emphasize that enough. So it is a quick prioritize. It quickly prioritizes care in mass casualty events. So that's why these tags were invented, to quickly prioritize the care of mass casualties. Okay, so it is globally used by emergency medical response systems and disaster response professionals. So kudos to nurses, emergency nurses that refined the triage tagging for disasters. And number 14 is early warning scoring system. The acronym for this is MEWS, MEWS, MEWS. So nurse leaders created risk scoring to identify patient deterioration. Early warning signs. What are you looking for when a patient is deteriorating? You don't want to sit there and drop the ball and let things fall through the cracks. You want to catch it and save lives. So it reduces ICU transfers, um, meaning the if, a patient um, needs to be transferred to ICU. What are the what's the tool we're using? How are we scoring that? How are we appropriately elevating the care of patients from med surg to ICU, from uh, uh, yeah, from a lower level of care, lower level of care to a higher level of care, right? So it reduces ICU transfers and improves safety. Okay, so nurse leaders were the one that created the meals, an example of that. So if you do have a scoring system for early warning inpatient deterioration and you're using a different scoring system, please let me know. Please do that. Number 15 is telehealth nursing protocols. Listen, I became more and more in tune to telehealth nursing during COVID. Prior to COVID, yes, I knew about it, but I really did not use it as much prior to COVID. So for you all out there, what tools are you using for telehealth nursing? So nurses shipped virtual assessment and triage standards, right? They recognized that we needed to have standards in how we conducted care for patients virtually, and they created one. This is a remote evaluation and monitoring tool. It is expanded across um, uh, geographical locations, and it being virtual just means that you can be in any part of the world and use it. Okay. And if you ever use any of these tools, please let me know. um Let me say here, pandemics in rural areas are using these as well. Some of those hard to reach zones, those terrains that uh they are not easily traveled. So, and they do have networks, network connectivities. You can use telehealth nursing that way to reach your patients within minutes and seconds, to communicate with them and meet their medical needs. Okay. Lastly, on this category is in this category is remote monitoring systems. So nurses helped design wearable vital sign monitors that are integrated with clinical alerts. Nurses help to design that. So you may find some patients who are using telehealth and they have certain probes that are placed on them so that when we are monitoring and we can see their heart rates on the screen, we can see they can, check their blood pressure, and the readings can can be transferred into our systems. So nurses designed these integrative clinical tools. All right. So it helps to track heart rate, SpO2 levels, our respiratory rate outside traditional settings. So you have that patient who is on home health care and you want to check on them weekly, or how so often you want to check on them. These are very um, integrative tools that help to have even the family members do vital signs and have it, cross over into the electronic records that we have. It enhances home care and chronic disease management. One of these tools I would say really comes in handy is for patients who have congestive heart failure and they need to check their weight daily, and or they may be on a weekly regimen, but it helps us to track their weight gain, because if a patient is gaining weight while they are on treatment for congestive heart failure, it triggers the alert that this patient heart is not, properly functioning to in or they are systemically, they are fluid, they are experiencing fluid overload, and that can make it very hard for them to get oxygenation to their vital organs. You find these patients, they start to become short of breath when they do activities, and those are signs that they're gaining weight. So when it's we use these daily weight, the scales, then we were able to transmit these data into their electronic records. I say simultaneously they're able to transmit their weight, their weekly weight, and or morning weight. First thing in the morning, they weigh themselves, and or it could be any other thing you're monitoring, like your blood sugar level. So yeah, nurses are really inventing things out there. Midwives are doing the same. And we need to tell these stories so people can know we're not just sitting around. And who's to say we're not professionals? Whoever ever made that, wrote that bill, the so-called big beautiful bill, needs to be reverted. And I pray to God it get canceled, because nursing is a professional degree. Okay, I repeat that nursing is a professional degree. Get it to your head, get it in your brain, get it in your cells. That if nurses did not, and midwives and nurses did not invent these tools, we would still be in the dark ages today. I mean, very dark ages, like the medieval times when things were not invented, and doctors did not even have nurses working with them, right? And Florence Nightingale came and said, listen guys, nurses got skills and nurses are scientists. So here we are today. Nurses and midwives are inventing life-saving tools, writing protocols, doing research, evidence-based practice research, and making our lives better, improving patient care outcome. And we should tell these stories so the world can know what's up. Okay. Here we are. Let's see. Thank you, Kendria. She's all right. Yeah, telehealth nursing really sounds interesting. Hey, that is another story for another day. Telehealth nursing is amazing. It's and how you call it, a clinical setting. I would say it is a specialty, not clinical setting. It is a specialty that is worth talking about, right? On that point, Kendria, I would just to enlighten you on telehealth nursing. Some hospitals in my region here, nurses can do admissions virtually, right? If a patient is in a hospital, a nurse can be home and do the admission for that patient, so other nurses within the clinical settings can continue doing their job and don't have to stop, you know, providing patient care to do that admission, right? So nurses can virtually project a camera within the patient's room and ask them questions and do their entire admissions from the comfort of their homes and or from an office, and that nurse is doing that constantly throughout the shift. So you're right, it is amazing and I love it, because when you have that patient care assignment and you have 6 patients to one nurse and or 5 patients to one nurse, whatever the patient nurse ritual is, you just know that you don't have extra time, and our job is sometimes just too hectic to stop and do an animation, and sometimes you get more than one admission per shift, and that virtual nurse is there. She's your backbone. She's out there to help you remove some of those burdens of caring. And lastly, you have virtual nurses who are just monitoring falls, right? They're just making sure when a patient is trying to climb out of bed, they speak to through the intercom and say, Mr. Joe, sit back in bed. What do you need? And then that nurse can call the primary nurse and say, hey, this patient needs pain medication, and or this patient is climbing out of bed, they will fall. We've been able to prevent a lot of falls that way. So virtual nursing goes into other areas. And if you have a virtual nurse clinical pathway at work, let us know what that is. What do you do? What do the virtual nurses do at your job? Okay. All right. Next category. We're almost at the end of this presentation, this conversation. And this category now, I'll take a sip of my tea and you do the same. Wet your whistles. That was more than a sip. My tea is getting cold because I'm not sipping it too often. But I needed to wet my whistles there. Do the same. Tell me what you're drinking. What kind of tea? Mine is a herbal tea, and it's for my stomach. This help calm my digestive system and boost my metabolism so I can look fabulous in the new year. All right, let's keep on rolling. So, and my nose is itching. Okay, back to the back to the topic. All right, so infection prevention and safety. I wish Nurse Ruben was here. This is his specialty. He's an infection prevention specialist. Also, another person in that category that comes to mind is Mr. Elvis. So Nurse Ruben is in Nigeria. He's from Nigeria, but he's assigned now in Sierra Leone in this role as an infection control specialist, infection prevention specialist, and Mr. Elvis is in Cameroon. And if you are an infection prevention and safety specialist, please let me know that in the comments. Tell me what you do, what country are you based in, and tell your nurse story. You see, we have so many reasons to tell our nurse stories, okay? So, all right, back to number 17, needleless IV system. Whew. I can remember when I first got into nursing, this was such a topic. Needle sticks, nurses and midwives getting stuck by sharp, shops, right? You give that injection and you get stuck with the same needle. And now you're wondering, have I contracted some infection from this patient that I just gave this injection to? And that is if I've had any incidents in my professional career. I've been stuck by a dirty needle, and I was devastated. And if you've experienced that, please let me know as well. How did you feel? I had to get tested for any and everything that that patient could have had. The patient was combative, and after giving them their, can't really remember what it was. It's been so long ago. It's been at least, I would say, 13 years ago. Don't know what the medication was, but I had just given. Oh, thank you. It was Ativan that I gave. I am, and when the patient moved his arm, I got stuck with the needle. So I got tested, and everything came out negative. But yeah, here we are, infusion nurses, co-designed systems to prevent needle stick injuries. It reduces risk for clinicians and patients alike, right? It improves workplace safety globally. And we do have several systems that have been put into place over the years to prevent needle stick. They have the retractable syringes. They have the um, yeah, retractable syringes that after giving that injection, once the puncture has happened, the needle can be retracted, and really it is a safety nest. I can't express enough what peace of mind that brings to nurses and midwives at the bedside, really. And also for patients who do their own care at home, it helps to prevent their family members getting stuck by needles. It really helps. Insulin needles, tuberculin needles, stuff like that. All right, next on this infection prevention and safety is hand washing and infection control audits. Wow. How else do we know we're doing right by our systems or by our patient care provisions? How else do we know if we need to improve the care we provide when it comes to infection control? Hand washing in general needs to be audited. Some people don't wash their hands. um, Doctors don't wash their hands. If you do know some doctors that go into patient rooms without sanitizing their hands, I'm sorry, my friends. If you're a doctor, or the medical doctors, meaning, um, they are notorious for going into contact precautions and or sometimes even airborne, let alone airborne, where your lungs are inhaling all these particles that are not good for you. But mainly with hand hygiene, they don't sanitize going in, coming out. They don't, and they're spreading the germs. And besides doctors, there are some nurses and midwives and other ancillary staff that don't practice hand hygiene. So we need to audit them. We need to see who's doing what and which um, populations doing the worst, and or how can we educate the entire team, right? So that we don't share the germs. And this is why cross contamination happens, because someone did not wash their hands when they took care of that patient, and going into that patient care, they did not sanitize their hands. So they take germs from one patient to another patient. Is terrible and it's unacceptable. So, building on the Nightingale's legacy, nurses developed structured hand hygiene protocols and monitoring systems. So let me know, how are you auditing proper hand hygiene practices and infection control regimens in your settings. And yeah, tell me, what are you using? What protocols are you using to audit proper hand hygiene practices? So this standardizes the healthcare infection prevention across the world. It reduces hospital acquired infection rates, right? And improves outcomes. So HAIs are being reduced because of the auditing systems that we have in place today. So what are you using at work? I am highly interested. Stop here and see what our friends are saying. Yes, Kendria, you are so right. Let me see what you said about needle sticks. As someone who is needle phobic, I love this development. Absolutely, girl. I am not only needle phobic by any other reason, but I've been stuck by a needle, by a dirty needle. And thank God it only happened one time, and that patient did not have HIV. hepatitis C, um, uh, Hep B, or anything like that. It could have been anything, right? It could have been any bloodborne pathogen on that needle. But praise the Lord. Thank you, Lord. 26 years of doing nursing. I've been stuck one time, and I bless God for covering me all these years. And I do pray, and these are some of the reasons why Nurses in Charge Global, we have a monthly prayer section. On the 7th of every month, we meet and we pray for nurses and midwives globally, because a lot is happening out there to nurses and midwives. And if we're not prayerful, the devil is out to get us, and the devil is getting us. And we just need to keep prayerful and pray for nurses globally. It is our God given responsibility, guys, to pray for the saints out there, to pray for, um, the nations, pray for leaders. So, Nurses in Charge, that's our faith outreach community. That's what we do. We do that, and we do it. We love doing it. Praying for nurses and midwives. So if you're getting miracles in your life, it could be, from our prayers, answers from our prayers, okay? Breakthroughs, answers from our prayers. We pray for everyone and anyone out there, especially our nurses and midwives in the field. So yeah, Kendria said hand washing is number one. If there was any other number that's bigger than number one, that's that number, right? Number one, number uno, hand washing. And if you're not doing anything else, wash your hands before and after. So thank you so much, Kendria, for chiming in. Yes, girl. Hallelujah to that. We have to support each other at all costs. Alrighty, my friends, we are making waves here. Moving on to community-based, community and global health innovations. Alrighty, number 19 on my list is clean birth kits. Clean birth kits. Midwife led. This is a midwife led initiative. So nurses and midwives packaged sterile birth materials for low resource areas. This brings a major smile on my face, because Nurses in Charge is organizing our first medical missions for 2026, and this is going to be in December of 2026. So if you've never done a medical mission, a venture initiative, and you are looking forward to that, no matter what part of the world you're from, check out our website, and under events and projects, that category, you will see under there calendars, calendar events. And then under calendar events, you will see an entire year of events, calendar year events. Can't say what I need to say, but you will also find that we have started meeting and planning for our medical missions coming up. So I say that because of this invention here, and I would say initiative, where nurses and midwives package sterile birth materials for low income geographical areas. So we will be carrying the kind of supplies with us to give out to hospitals in the hard to reach regions. We'll be serving orphanages, homes for the widows and widowers. And our medical mission this year, we're looking to go to Kenya. So if you are out for it, email me. Let me put the email out there. Email me, let me know. I can put you on the list, and you can be part of our next meeting. Okay. So yeah, we're doing our medical missions. So this really enlightens me. It helps me to see how we are coming along over the years. So these clean birth kits ensures hygienic deliveries, right? It also reduces maternal and neonatal infections and death. We know that some regions around the world have a high mortality rate for neonatal, maternal and neonatal patients, populations. So, what a brilliant idea and or initiative. The next one is the kangaroo mother care advocacy, right? So, it is promoted by nurses and midwives in resource limited settings. So this is a skin to skin care for premature infants, right? The use of this kangaroo mother care advocacy is for, promoting that bonding. Patients, preemies are born and they need that nurturing, and just the skin to skin um, uh, practice really helps the preemies to start developing and growing healthy. And some of those preemies, I'll tell you, are babies that are born by uh, narcotic narcotic abusers, mothers who are using, um, abusing alcohol or some form of drugs, illicit drugs. When these babies are born, they really struggle, and part of their treatment is the skin to skin nurturing by their mothers. It really helps the preemie to start developing mentally, to start developing physically as well. It improves the bonding, thermoregulation, um, helping their the core temperature to raise, and improving survivor in general. Already, the last category here I'm going to speak on is education and professional development. If you all know me, you know that I'm very much passionate about professional development, and this is one area that really, 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 really brings joy to my heart. So 21 on this list of innovations by nurses and midwives is simulation based nursing education. This semester, this is what I'm teaching at Rasmussen University. I'm teaching a maternal child simulation, and I love it. It's laid back, no stress. Last semester, I taught mental health. I'm an adjunct, so I pick up courses here and there, and it just helped me to diversify my portfolio. It helped me to brush off my skills, right? But yeah, simulation based nursing education was developed by nurse educators, um, high fidelity simulation labs and virtual clinical scenarios were developed by nurse educators. It is amazing. I'm telling you, if you before you go into the clinical setting to work on live breathing warm patients, you can make all your mistakes in the simulation lab. This is the safe environment where you can harness your skills, cultivate your clinical skills before you get into the clinical settings. And listen, the mannequins being used, our patients in the simulation labs, can range from anywhere from $50,000 US, 50,000 US dollars to 300, 500,000 US dollars. And the most expensive ones really come with more human-like um, feeling and functionalities, and you'll be amazed. You touching a mannequin that feel like the skin feel like human, and they breathe, they cough, they sneeze, um, they have a heartbeat, They can birth a baby. They can hemorrhage. Um, they can have asthmatic attacks. You name it. The most expensive they become, the more functionality they have, and it just it bring realistic experience for the nursing and midwife students. When I did the nationwide tour in Liberia, I was blown off my feet. And this is what the documentary is meant to really show you, that things that people never talk about. So Liberia has a requirement. It is a standard of practice that every training facility for nurses and midwives have a simulation lab. I never knew that until I did this documentary, and it really opened my mind. I am so impressed. I am so proud of a nation that has been classified as one of the poorest nation in the world, and their standard of practice for nursing education, professional degree, right? For nursing education, midwifery education, is that they must have a simulation lab. And the requirement is there. They have their policy in every school of nursing and midwifery education must meet the requirement. Otherwise, they cannot operate. They cannot open their doors for education to educate nurses and midwives. I was like, wow. We got into some terrains where they were remodeling to be recertified because maybe they no longer meet the requirements. So it was amazing. I learned so much, and I walked away from Liberia feeling so proud of my home country, so proud of Africa amongst all of the developed countries, right? And not all schools, even in the US, if you are one of those schools in the US, of all places, where this is a developed nation, right, as compared to the underdeveloped nations like Liberia, and you do not have a simulation lab, please tell me. Please let me know. I am very much interested to know why. Why don't you have a simulation lab? I mean, it's expensive. It's very expensive to own one, but if nurses and midwives can practice safely before they touch a human being that they can make a fatal mistake with, you can do that. It is the best thing we can provide in this 21st century um, era. Okay, so yeah, I went off on that part, but really, the use is that it is for safe practice environment for students. It provides a safe practice environment for students, and it improves clinical judgment and readiness. Okay. Next on this list, number 22, is nurse coaching and holistic care models. All right. So leaders like Barbara or Dose integrated wellness, spirituality, and self-care methodologies, right? It supports holistic patient and clinical well-being, holistic patient and clinical well-being, clinician well-being, sorry. Really, so we have nurse coaches, right? It may not only be in holistic care, but today many nurses have gone out there in the nursepreneur um arena. They have their own businesses. They are certified. They may be internationally certified or just nationally certified to be holistic, to be nurse coaches, and they do have their businesses. And we have quite a few of these coaches as members of nurses in charge as well. So kudos to you all out there. We need your nurse story. Why did you go into coaching? What do you coach? What's your niche? Please share that, because we like to feature you and bring recognition to what you do. Alrighty. Last on this from this category is nurse influenced in electronic health record design and usability. So nurse informatics shaped user-friendly electronic health records. The integration of electronic health record system has made life so easy. I cannot I cannot emphasize that enough. I remember when I got into nursing back in the dark ages. Imagine when I got out of nursing school, or when I was in nursing school, doctors were writing prescriptions, we had to transcribe their prescriptions. We had to transcribe it from the medical record, and you know write it under prescription, and then send it to pharmacy. Pharmacy then would now take that and dispense these medications to us, and or the treatment that was ordered, we can carry on the treatment. Listen, trying to read doctor's handwriting, whoo, good luck. And besides the documentation, what about, besides the physical documentation, what about the portability of medical records? You can be in Africa, in Europe, and a patient medical record can be sent directly to you. You can access it and take care of that patient and really see it. So electronic medical record designing and usability by nurses and midwives is amazing. It says here nurse informaticists. Whoa, they shaped this area. The electronic record, it reduces documentation burden, as I was trying to describe to you now, and it improve workflow. It also increases efficiency and safety in patient care. So that is amazing. That is so amazing. Next time, and we go into this topic, I will definitely cover other inventions that have been done by nurses and midwives. But listen, I've talked for almost 2 hours, and I want to let you all go. I was just having so much fun. I don't know about you, but I appreciate those who stayed with me, those who came and commented, like Kendria, Minister Francis Port, Nimley. Who else came along? There was somebody else. Don't want to miss a name. I truly appreciate you guys. Those who are watching afterwards and will be, D Roberts in Liberia. I knew there was someone else. I appreciate you ladies for joining me, and I appreciate those who are watching this recording and commenting to the areas that I'm interested in knowing from you. I appreciate you all. Please join me again next Sunday for another amazing conversation. I appreciate you all. Have a blessed day. May the good Lord shelter you with love, healing, and your heart desire. Whatever it is that you're praying for, may God provide it all to you. May God cover your family. May God bless your hands as you take care of your patients. May this week be such a blessing that you come back to give your testimony as to how God is blessing you, how God has opened doors for you, how your new year is productive, how God saved your life, saved your patients' lives. I like to hear those testimonies here. This is a strong pursuit of nurses in charge to empower nurses and midwives globally, to share your faith, to pray with your patients, to pray for your patients, to pray for your fellow nurses and midwives. And we can live live and lead meaningful professional career journeys as a global community in all of our capacity. So I say thank you again. Remember that we are honoring the trailblazers among us, honoring our pioneers of nursing and midwifery, and do not miss our second annual event, our second annual Kickstarter event coming this Saturday, January 17th. Invite someone. It's a free event. You don't have to pay for it, but you will walk away feeling so blessed. You'll walk away learning a whole lot more than I could say today. And share your nurse story. Tomorrow is the last day to submit your intention to participate in this event. Okay. And don't be silent. Don't be silenced. Don't be silent and don't be silenced. Okay? Speak up and don't let anyone shut you up. Do not let anyone do that to you. In this day and age, nurses and midwives should speak up. We should hear about you. We should hear about what you're doing. The world should hear about what you're doing um, in your area. And yeah, share your nurse story, please, people. And Nurses in Charge is here to anchor you in that area to support you. Already, Sis Francis says she's giving me her blessings. I love it, Minister Francis. I appreciate you. I can take all the blessings I need for this week and the following week and the rest of my life. So thank you. I love you, sis. Thank you for staying in my corners. I always know you're right there. Like when I'm thinking and hearing, I can hear your voice. I know so much about how you empowered me over the years. So thank you so much for coming today, hanging out with me on this Sunday. Um, and yeah, and since I'm recognizing Minister Francis, I want to tell you all out there, if you do not have a faith-based community that you hang out with on a daily basis, that you pray with on a daily basis, that pray with you on a daily basis, I do know an organization called the Virtuous Women International Missions. This is how I found myself. This is how I found my calling. I was hanging around with them. God brought me into this community, loving. All these women are amazing. It's a global ministry, and we meet daily. We pray twice a day. We have ministries within this organization that are serving women and children and families. And our mission is to stand in a gap of prayer for the nations and families. And so they, hanging out with this team has really transformed my life. And here you go. Here's a little bit about them there. That's the phone number. And if you are interested in knowing more about the Virtuous Women International Missions, I can share more with you, because to God be the glory for bringing them in my life. They really have been a therapy for me in many areas of my life. So um, I am very much pleased to recognize them, speak about them, and Minister Francis Port, namely, is the founder of Virtuous Women International Missions. If God had not connected me with them 5 years ago, I wouldn't have found God is awesome. He would have done something else, but I know that He brought me into this ministry. And I was able to find my calling, find my purpose in life. And at that time, I was burnt out. When I got assessed by psychiatrists, they did a good assessment and then told me that their workload was very large and they could not help me. Then I turned to God and turned to this family Virtuous Women International Missions, and they have been my therapy. God had used them to be my therapy section. And today I'm a stronger woman than I was 5 years ago when I was burnt out. I was discriminated at work. I was broken um, spiritually. I was just drained. And coming to know the Virtuous Women International Missions um, has turned my life around for the better. So I'm grateful, and I can share the ministry with anyone out there who is struggling with burnout. This is a burnout prevention ministry within itself and other things they do. I do lead the health professionals within this organization, the Virtuous Women International Missions. I am the health professionals coordinator. So join me there as well. You will see them as well during the Kickstarter event, and you will hear from Minister Francis, and you'll learn a lot about the Virtuous Women International Mission. So um, we need to continue to anchor ourselves in Christ, anchor ourselves in our faith, and don't ever be ashamed to say that we're Christians, we believe in Jesus Christ as our personal Savior, and smile about it and tell the world about it and save somebody's life so that they can come to the saving knowledge of Jesus Christ. So that is my story. My name is Dr. Nyeku Kimoho. I am a nurse by blood, and I'm blessed to be with you all today. You have a fantastic week. Have a blessed week at that. And see you next week. All right, friends. Love you all. And God love you the best. Bye.